Good day and welcome to the Pediatric Blood Cancer Initiative and Advances Regarding Bone Marrow Stem Cell Transplant call, hosted by the National Bone Marrow Transplant LINK. Today's conference is being recorded. At this time, I would like to turn the conference over to Jennifer Gillette. Please go ahead, ma'am.
Thank you, Sarah. Yes, my name is Jennifer Gillette, and I am the staff social worker at the National Bone Marrow Transplant LINK. I'd like to welcome you to our Lunch and Learn with the LINK. This month's program will focus on pediatric blood cancer initiatives and advances regarding bone marrow and stem cell transplants. A special thank you to our partners for this call today, the Leukemia and Lymphoma Society. LLS is dedicated to curing leukemia, lymphoma, myeloma, and other blood cancers. They are the world's largest nonprofit health organization dedicated to funding blood cancer research and providing education and patient services. We also appreciate their partnership with these much-needed programs. Thank you also to our sponsors, Jazz Pharmaceuticals, Insight Corporation, Pharmacyclics, and Janssen, and our esteemed LINK partners for making this program possible today. Just so everyone knows, I'm going to give a general outline for how we're going to go today. There's going to be a brief introduction by myself explaining some things about nbmtLINK, the National Bone Marrow Transplant LINK. Then we'll have our first professional speaker, Dr. Gwen Nichols, and she's going to discuss pediatric initiatives at LLS. And then our second speaker is Dr. Curran, and he will discuss advances in pediatric transplant and CAR T therapy. And then we're going to have Michelle Marks, a mom and caregiver, speak about 10 minutes on how she and her family experienced AML with their youngest son, Quade. And then we're going to try to allow some time for questions, and then I will do a wrap-up at the end of the hour. For those who may not be familiar with the LINK, nbmtLINK is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are our webinars, podcasts, blogs, lunch and learn calls for a variety of topics such as chronic graft versus host disease or disease-specific information, caregiving, coping, treatment options, and survivorship after a transplant. We also have a very active peer support mentor program for patients, and that's also available for caregivers and donors. Our Second Birthdays Recognition Program, and then we have our books and emotional support from a licensed social worker. So please feel free to reach out to us if there's anything we can do to support you on your journey. Before we begin today's program, I would like to review a few housekeeping items to maximize the experience of all on the call today. Please be mindful in being concise with your questions so that we may answer as many as we possibly can today. Also, please know that the information provided in this program is meant to stimulate conversation with your own healthcare provider, and it's not meant to replace your individualized medical plan. So now, on to the educational part of our program. We are so thankful to have our first speaker with us here today, Dr. Gwen Nichols. Gwen Nichols is an adult hematologist oncologist. As LLS's Chief Medical Officer, Gwen plays a critical role in advancing cures through a unique combination of clinical, academic, and pharmaceutical experience. She oversees LLS's scientific research portfolio, services, and policy, and advocacy initiatives. A physician and scientific researcher, she has dedicated her career to advance cures for cancer. Thank you so much for joining us, Dr. Nichols.
Thank you so much and thank you to nbmtLINK for allowing me to speak today. I really appreciate this opportunity. LLS started 70 years ago, more than 70 years ago now, by a family who unfortunately lost their child to leukemia. In the 1940s, this was a disease we really had very few options for, and we have kept true to that mission of trying to find new therapies for leukemia, and now for leukemia, lymphoma, myeloma, and all of the blood cancers. But we realized LLS has a very vigorous research program, and over the last 3 years, there have been more than 50 new agents approved in the blood cancer space by the FDA, and we're very proud of that because we can trace for 95% of those agents LLS research funding at some and sometimes multiple points in the development of those molecules. But what we also realized, and when I came to LLS a few years ago, those advances, very few of them are advances that have been impactful for pediatric cancers. And while we're very excited, and you're going to hear more from Dr. Curran about CAR T therapy, LLS has been supporting the research that brought CAR T therapy forward since the early 2000s. And so that's our shining star of new therapies for pediatrics. But we understood that the development process, that we've been really successful in moving research that then gets picked up and used by pharmaceutical companies, wasn't translating to children. And part of that is because, thankfully, childhood cancers are rare, but that doesn't mean that our most valuable resource, our children, shouldn't have the benefit of new therapies. And so we decided that we needed to put more emphasis on how we could help development of new therapies and more targeted therapies for childhood blood cancers. And so about a year ago, we started what we call the LLS Children's Initiative. It's a multi-pronged effort that will be a multi-million-dollar effort to try and bring both increased research and a specific pediatric blood cancer research program, increased services for parents, for teachers, and for children, and advocating with many of our wonderful partners like nbmtLINK to be sure that there is pediatric research funding and that continues in Washington. And besides this new research and patient services effort, we have also initiated the underpinnings for a master trial for relapsed pediatric leukemia. Now, what is a master trial? Well, a master trial is sort of turns the paradigm of clinical trials around on its head. The idea, most clinical trials, and I worked in the pharmaceutical industry, clinical trials are designated or created in order to move a drug forward in development. The company has an agent. They think, what is this best going to be used for? And then they try and develop that drug in the indication that they're thinking about. The whole process is around the agent itself and moving it forward to get it approved. It's a very valid and important part of drug development. But the problem is that pediatrics is not a big market, and so it's rarely the choice of a drug developer when they want to bring a molecule forward. We need to do something about that, and so a master trial is in fact about the patient in the middle and trying to have as many different trial options in one place at the same time so that you understand the biology of the patient, their biomarkers, and then have the patient and their doctor be able to select multiple different possible therapies and find the one that matches the patient. This is a potentially very efficient way. If you're going to be doing sequencing and biomarkers for a targeted therapy and trying to choose the right target for a patient, a company who has only one molecule and only one target needs to test hundreds of patients to find one or two that fit their trial. That costs money, and it costs patients' lives. In this effort that we are beginning, that we call the PEDAL trial, the Pediatric Acute Leukemia trial, we're going to take on all of the testing of the patient and then have multiple pharmaceutical companies participate with us so that we can allocate patients to different arms. This will start for relapsed acute myeloid leukemia. And we're very excited. We've had meetings with the FDA, and we are going to have our first official meeting with the European Medicines Agency in October. We believe that this trial will begin in calendar 21. And so we're very excited to move this forward. I mentioned the European Medicines Agency because not only do we have the NCI and the Children's Oncology Group as a partner in this effort, but we have 5 different pediatric consortia in Europe who are going to participate. And so this is a very exciting way to have enough patients to answer questions and move a therapy forward in development. Why is this important for bone marrow transplantation? Well, we know that for patients to do well with a life-saving bone marrow transplant, it is best done when the disease is in remission. And when the therapies are less toxic and the patient doesn't have complications from prior therapy before going to transplant. We believe that this trial will be a great way to get patients to life-saving transplants because we will be giving them less toxic therapies and maybe even avoiding the need for transplant, which I think every bone marrow transplanter, and I was one in my past life, would like to see a world where we were no longer needed. So I think that LLS is working with the pediatric world to try and make a real change in how new therapies are developed. And we're very excited to include all of the research, not just for leukemias, but for childhood lymphomas and other blood cancers as part of this children's initiative. And I really thank nbmtLINK for allowing me to talk about this. Thank you so much.
Well, thank you for talking about it. We are so excited to share that there is hope on the horizon, and we're so thankful for all the work you all do at LLS. So thank you for joining us, Dr. Nichols. And now we will introduce our next speaker, Dr. Kevin Curran. He received his medical degree from Georgetown University and did a residency at Tufts New England Medical Center. His fellowship was in pediatric hematology oncology at Memorial Sloan Kettering Cancer Center. He is a pediatric oncologist who specializes in bone marrow transplantation, and he treats children and young adults who have malignancies such as leukemia, disorders of the bone marrow that impair the ability to make normal blood cells, and the disorders of the immune system that impair the body's ability to fight infections. His research focuses on the development of novel treatment approaches for leukemia and lymphoma that do not respond to current therapies. Specifically, he and his colleagues use genetic manipulation of immune cells to recognize and kill cancer cells. This is a promising form of gene therapy and is currently being tested in clinical trials at Memorial Sloan Kettering Cancer Center for children and adults with high risk of relapsed hematologic cancers. Through these are highly innovative studies, we hope to provide a novel and successful treatment option for all patients with cancer. So thank you so much for joining us today, Dr. Curran.
Thank you so much, and thanks for the opportunity to discuss pediatric cancer
and all the efforts that the entire nation and a really dedicated group of pediatric researchers are doing to make this better. And thanks to the nbmtLINK for hosting this and for LLS for supporting this. And I'm going to echo a lot of the things that Dr. Nichols has been saying. If you're on this call, you have it's close to your heart. You have the spirit to improve the outcome for children with cancer. And as Dr. Nichols mentioned, it is a very rare disease. It does not feel rare to our patients and to their families. It really turns their world upside down, and that whole idea of a rare disease really goes out the window when they come and see us. At that point, we really have to try to educate them and help them along the path, because the beautiful thing about pediatric cancer is we have come a long way. We have excellent survival rates, not only in leukemia and lymphoma, but a lot of the different malignancies that afflict children. However, those treatments can be toxic, and one of the goals of all of us is to make better treatments. We're very happy with having patients have beat their cancer, but what we need to do is have treatments that are less toxic and have less long-term impacts. Of course, we need treatments as well for the patients who fail to respond. And so the focus really of researchers are those two efforts. How do we make better treatments that work better and are less toxic, and patients don't have to endure years of chemotherapy? My clinical practice is in bone marrow transplant. My research focus and part of my clinical practice is I lead the Pediatric Cellular Therapeutics Center at MSKCC. Within that center, we have a multidisciplinary group of cell therapists, not only in pediatrics, but outside of pediatrics. We bring the entire group together, really trying to find better targets for cancers and better treatments. In regarding bone marrow transplant, and bone marrow transplant was the original cell therapy. It's the original immunotherapy. Immunotherapy is a new form of therapy. It's where we use the immune system to fight disease. Cancer immunotherapy is, of course, fighting cancer. Bone marrow transplant was the original one, and we've made great strides, and we've made excellent benchmarks on reducing complications to bone marrow transplant, reducing infection rates, improving survivals, and curing cancer. But we have a lot of ways to go. We have to reduce the complications, such as GVHD. At our own center, through support of the LLS and really a long-standing commitment from them and from other groups, we have ways of manipulating the stem cells from the donor to try to reduce it. And that's one option. But there's other options out there, too. There's actually genetic modification of stem cells, looking to see if we can make better stem cells or more tolerable stem cells. If you have complications, there's also treatments after, such as IL-2 therapy, which was supported by a lot of the different research groups, really trying to improve the immune system's ability to suppress itself so it's not overactive. Again, my real focus, though, and Dr. Nichols put it very succinctly, I'm a bone marrow transplanter that has the ultimate goal of reducing and hopefully eliminating bone marrow transplant. And I hope to see that in my career. I was lucky enough to enter a preclinical lab at MSK during my fellowship. I knew my passion in life was really taking that preclinical idea and spark, that wow moment, and bringing it to the bench. So I knew that's what I wanted to. But to get a fundamental understanding, I was in the lab to understand how do we actually go to the bench, figure out how to target a cancer, and use that to the bedside. And so with that, we have a couple trials at MSK targeting CD19, and Dr. Nichols mentioned how the support from LLS really supported the FDA approval of this CD19 therapy for pediatric and young adult patients with leukemia, and hopefully eventually we're going to extend that also to lymphoma patients. But we're not done yet. And while we are now able to offer patients who otherwise would not respond to chemotherapy, we can offer them CAR T cells. Think of your CAR T cells as a pair of glasses for your immune system. If you're unfortunate and have cancer, your immune system is not seeing or getting rid of your cancer. And what CAR T cells is we pull out the T cells, which are good, they're not cancerous, and we use genetic modification. So we use viruses to insert a DNA into the cells. And now these new T cells, these CAR T cells, have been given sight. And when we infuse them back into the patient, they eradicate the leukemia, they eradicate the lymphoma. And work at our center and many centers, a lot of it supported by a lot of organizations, including LLS, really ultimately was able to take this from something that started really working in 2009 and in a short period of time was given FDA approval, and now we have products that we can offer our patients. But as we've said, we're not done. I know our center is working on 2 different AML-specific CARs, and we're not limiting it, and we have multiple myeloma CARs that are now coming out, and really the cell therapy field, we hope, will really expand beyond blood cancers, and hopefully will provide a cure for a number of different cancers. But we need really smart trial design. We need the support of everyone on this call. We need the support of foundations that have the foresight that if we have a good option, how do we get it to the patient? Dr. Nichols mentioned a master trial, and really this in pediatrics is the only way to do it. It's the only way to do it is to bring several centers together, leading centers, and then bring in sub-centers to really recruit the patients, bring in those patients, analyze the samples, figure out where the defects in the cancer cell is that we can exploit, find ways we can exploit it and eradicate it. And so I do thank all of the work by everyone on this call for that. And we're very excited for our AML CAR program that we're developing here and for a lot of other cell therapy programs that we're developing. And we thank you guys for your support.
Thank you so much. We appreciate you filling us in what's happening with your program and again, more hope for people on what's coming out. Now we're going to introduce our next speaker, Michelle Marks. Michelle lives in Denver, Colorado with her husband, Rich, their 14-year-old daughter, Lainey, and their 13-year-old son, Quade. Michelle earned a Bachelor of Science degree from the University of Colorado at Boulder and a Master of Business Administration from the University of Denver. She's spent close to 25 years within the medical device industry developing and commercializing innovative medical treatments. Currently, she's the Director of Global Marketing for Terumo BCT, a global leader in blood management, blood safety, and therapeutic apheresis, cell therapy, and cell collections. In 2016, Michelle and her husband, Rich, were presented with devastating news that their 9-year-old son, Quade, was diagnosed with acute myeloid leukemia with a monosomy 7, a deadly type of blood cancer not common in pediatrics. Quade was given 4 to 8 weeks to live without treatment. After months of inpatient hospitalization, 4 rounds of intensive chemotherapy, countless blood transfusions, all of which were collected on the equipment developed by Michelle's employer, and a stem cell transplant, Quade is now cancer-free. With a strong passion for advancing medical research and proven business leadership, Michelle is a strong advocate for advancing cancer research, ensuring access to affordable care and innovative therapies, and improving the lives of cancer patients and their families. Thank you, Michelle, for joining us. Can you tell our listeners a little bit more about your experience and what helped your family get through this?
Absolutely, and thank you very much for the opportunity to join this Lunch and Learn discussion today. While I would by no means consider myself an expert on pediatric stem cell transplant, especially with these esteemed individuals on the call today, I am a mom to a pediatric cancer survivor who received a cord transplant, and as mentioned, I will be sharing my experiences with his diagnosis, treatment, and also survivorship. So it all started on April 15th in 2016. I actually woke up that morning in Tokyo where I was and ended the day meeting with a pediatric hematologist oncologist in the emergency room in Denver, Colorado. It really did feel like a bad jet-lagged induced dream. So with news of a bad snowstorm in Denver, I took an earlier flight to get home and was looking forward to spending a weekend with our family. On the plane, I didn't think really once about all of the bruising and swelling we had noticed on Quade's legs and feet earlier that month. After all, he was a 9-year-old and very active and competing on a snowboarding team and playing competitive lacrosse. So as many of you can attest to, bumps and bruises are fairly commonplace. But soon after my husband picked me up from the airport, we received a call from the school nurse. Quade had visited her complaining of a swollen hand and a strange rash on his arms and legs. And so we went to his pediatrician, which resulted, in drawing blood for a complete blood count. And within a couple of hours, we were asked to immediately go to the emergency room. The conversation that followed was numbing, and I'm sure many have experienced the same. Quade had very low red cell counts and platelets, but elevated white cells. They indicated that further testing was required for diagnosis, but the symptoms were indicative of leukemia. Quade all the while just kept asking to go home. And when he burst into tears when the doctor said he had to spend a night in the hospital for additional test results, we don't think he really understood the meaning of leukemia then, or maybe he hadn't heard the doctor mention it. He was crying just because he was going to miss his lacrosse game the next day. And throughout that night, I really kept holding on to hope that it would be something else besides leukemia. I convinced myself that our family really had this hall pass on cancer because we had experienced so much loss to cancer already. My grandmother, my mother just 8 weeks after Quade was born, my dear uncle, and my best friend from high school. But within 24 hours, Quade had a bone marrow biopsy, a lumbar puncture, a double testicular biopsy, and the placement of a Broviac central catheter. And as any parent can confirm, Rich and I felt all those pokes and pricks far differently than Quade. Certainly not a physical pain, but one that's in your gut. And we kept telling ourselves we had to be strong, but we were certainly holding back our own tears. The results came back with the diagnosis, as mentioned, of acute myeloid leukemia. And Quade had 6 to 8 weeks to live if he didn't immediately start treatment. Genomics testing soon revealed the presence of monosomy 7, which pushed Quade into a high risk for relapse category. Quade was concerned about spending one night in the hospital, and suddenly we were faced with months of hospitalization. And this is the same kid who just 6 weeks prior had won the snowboard giant slalom for his age group, and now he was fighting for his life. In total, he spent 168 nights in the hospital over 8 months to receive what was then the standard therapy protocol per the Children's Oncology Group guidelines. This consisted of 3 rounds of chemotherapy and a stem cell transplant, all of which required inpatient hospitalization until his ANC levels reached a certain point. So yes, we lived in a hospital. We learned how to live in a hospital. And it was hard. It was really hard. Quade had setbacks, GVH, infections, and experienced the heart-wrenching emotional and physical yo-yo that cancer brings, which often feels like 1 step forward and 2 steps back. And yes, it definitely had an impact on our daughter, Lainey, who, like so many siblings to cancer patients, often still feels like she is living in her brother's shadow. And yes, we carry scars, but most emphatically, yes, we beat it, and we are in this category of survivor. We first received the glorious news that Quade's blood and bone marrow had no detectable level of cancer during his 3rd hospitalization prior to transplant. And the pure joy we feel that the leukemia has not returned is really utterly indescribable. And while we're relieved and eternally grateful for Quade's superb medical care and the awesome support that we received, there is this nagging fear of long-term complications, and the paranoia of relapse is ever present. The thing I've learned is that this cancer-free moniker hasn't marked the end of our Brave Boys fight. One of the biggest misconceptions with pediatric cancer, as we've mentioned, is that once the treatments are finished, the battle is over. But with today's therapies, only 1 in 4 AML patients survives 5 years beyond diagnosis. And the consequences of these toxic therapies that we so willingly allowed to be injected into Quade's body to help save his life can often cause serious and sometimes life-threatening complications later on. But I really try hard not to be haunted by these facts because of the promising research we've heard about today, the targeted genomics testing and innovative therapies that enable physicians to really not only improve cancer survivor rates, but to do so with far greater precision and less toxicity. This promise is really what fuels my passion for supporting organizations like the Leukemia and Lymphoma Society, so specifically the Children's Initiative and the PEDAL Master Clinical Trial, which Dr. Nichols spoke about today. So I'd like to talk that, cancer does affect the entire family, and we are each forever changed because of Quade's diagnosis. But I do want to assure you that it is not all doom and gloom. Quade is now a 13-year-old 8th grader. He missed all of the 4th grade, but with a lot of hard work and tremendous teachers, he has stayed with his class in school. And now with a 504 in place, he is performing above grade level. He continues to play his beloved lacrosse. He skis and snowboards every chance he can get. And it is not uncommon for teachers, coaches, and spectators who are unaware of Quade's cancer diagnosis to speak about his grit and determination, which is uncharacteristic of other kids his age. Our daughter Lainey offers genuine compassion for others, and she started speaking with the Children's Hospital about volunteering with Child Life prior to the pandemic, because she really wants to help other kids who've gone through what her brother did. And Rich and I feel like we've aged years. If not physically, we are officially, what I say, emotionally ancient. And we are acutely aware of our own utter vulnerability in a way that comes from having your life turned upside down in a matter of mere seconds. And what we call our battle wounds that were once open and raw from the initial shock, denial, and agony of a pediatric cancer diagnosis, they have scarred, and they now rest in the shadows of insight and what we call the gift of perspective. We have all learned to appreciate the little things and let the inconsequential and petty stuff pass. And we have learned that we can't control tomorrow, but we can control how we live our lives today. Ultimately, we've learned what really matters most. So in conclusion, what are our key tips that I can offer you today? Quite simply, use the resources that are available to you through organizations like nbmtLINK, LLS, and many others. Really educate yourselves on the diagnosis and treatment. Be your child's advocate. You know your child best. Find a healthcare team that you trust and one in which communication is open. And don't hesitate to ask for help, even if that help is from complete strangers. Show gratitude. Try to laugh and be positive, even when everything around you seems to be falling down. Find a healthy way to vent and release when needed, and yes, it will be needed. And most importantly, have hope that there is incredible innovation on the horizon. So thank you again for asking me to speak with all of you today and share my experiences.
Wow, Michelle, thank you so much for allowing us in that space, that sacred space of knowing what you and your family has gone through and sharing your authenticity with us. I think these are great tips, and I'm sure there's a lot of people that are really relating with you. So thank you for being the heart of our program. Now at this time, I would like to have Sarah please share with our callers how they can ask questions.
If you would like to ask a question, please signal by pressing star 1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, that is star 1 to ask a question. Then we'll pause for just a moment to allow an opportunity to signal.
Have we got anyone calling in at this point, Sarah?
At this time, there appears to be no questions.
Okay. Well, I will ask a couple questions then, and if anyone would like to chime in at any time, Sarah, please feel free to interrupt me if we have another call. But I have a question for, first I'll start with Michelle. Is there anything, as people are just starting this journey, just finding out that their child has cancer, is there anything you would want to tell them that you wish you would have figured out earlier on in your journey?
Great question. I think I'm continuing to find resources and organizations that are available. So I really would encourage people to reach out to the licensed social work and child health services that are available and really ask for their input into what resources are available. And I think it's also really important to not be afraid to answer questions and to ask to speak with others who have been through a similar circumstance. A lot of organizations have a lot of volunteers, like myself, who have been through the diagnosis, and they really do try to match a similar diagnosis, similar treatment regime to an individual who is asking for some more information. So it's great to be able to speak with someone who is has gone through a similar path, and also other literature and other support tools that are available.
That is great. Thank you so much. Dr. Curran, I know nowadays there's a lot of people that are into a lot of different complementary therapies and things that they might want to try and concerned about different medications. When families come to you and say, I want to try this kind of alternative therapy or this supplement, how do you usually answer those kinds of questions?
I mean, without question, and I would echo what was already said, these therapies can provide a lot of benefit, especially if within your family or if your child, if these therapies are going to ease the journey. And I wanted to add on to what was just said. You are your patient's you are your child. You're the caregiver. You're going to always know them best. And I can say one thing about pediatric oncologists, pediatric bone marrow transplants, they will listen. We will listen to what you say. You just have to be able to understand we want to hear your voice. In terms of complementary therapies, I mean, a lot of institutions have integrative medicine groups. We have a pretty robust program. We're very lucky and fortunate in that. But outside institutions, you can find integrative medicine groups that will help augment the standard or medical therapy that your child is getting, and we welcome that. We anything that is going to provide relief, whether it's acupuncture or some vitamins or melatonin for sleep, we welcome all of that. There is actually a website we use, herb.com. It is by MSK, but it's an interesting website because what they've done is a compendium. And it's a compendium of all the different alternative medicine, vitamins and things. And I will be the first one to admit I am not an expert. And so I typically the first step is we go to that website and we see what the interactions are. Because chemotherapy can have a lot of interactions. and you have to confirm that whatever agent that your child or yourself is going to take is not going to have an interaction with the chemotherapy you're getting. And so safety is definitely the first priority, but we want to welcome any therapy that gets you through the journey.
Thank you. Dr. Nichols, I have one for you. As far as with all the different trials and things that families might be interested in hearing more about, granted, I know that the doctors keep up to date and are aware of what kinds of things are happening, but if families themselves want to look at different clinical trials or research, is there a site or a recommendation you have on something that's reputable but also easy to understand for families to do their research?
Well, I have one thing even better than that, and that is that LLS has a clinical trial navigation service. So when I was in practice, and I'm sure this is the same for Dr. Curran, you know the trials at your own institution. You may know the trials in groups that you cooperate with, but you can't possibly know every trial everywhere. And what you also don't know is, are they open? Are they accepting patients? Can you travel there? Can you get support for traveling there? How do you negotiate talking to learn more about the trial? Well, we have a group of 9 nurses, 2 of whom are pediatric oncology nurses, who work in our center. You call LLS and say, I'm interested in talking to one of the navigation nurses about a clinical trial, and they will, through their own research, find trials that are appropriate for your child, or your, in the case of an adult, for you or the person you're calling for. They will contact the center to be sure the trial is open. So if Dr. Curran has a trial, our nurses will call his nurse coordinator and say, I have a patient from Baltimore who's interested in coming in this trial. Here's their clinical story. Do you have space for them? What are the entry criteria? It's a really high touch way to get a list of available, open, appropriate trials that you can then take back to your own doctor to discuss. The idea is we are there not to give medical advice, but to do a lot of the legwork so that your doctor's office doesn't have to do that. We're hoping to be physician time savers in this. And so I would encourage anyone who is looking for a blood cancer trial to contact LLS and ask about our clinical trial navigation. And you can learn more about that on lls.org.
And Dr. Curran, I would definitely make a plug for that. I have been contacted by those nurses, and it's just a great resource. They can advocate for you. They speak the language. They understand the complexity of entering in clinical trials, because there are complexities that we need to get through, and they're just a great resource. So I've worked with a number of patients that were referred to us through that service, and I really strongly encourage anyone to reach out to it.
We can also provide,
pardon the interruption,
travel support.
We do have a few people.
Can be incredible.
Well, thank you. Let's get to our caller, and we'll get that question.
All right, we'll go ahead and take our first question now. Please go ahead.
Hi, Michelle. Firstly, I want to say thank you for sharing that story. I can't even begin to tell you how much it meant. I actually had a transplant myself for MDS, just within the last couple of weeks, my friend's daughter's baby, who's 8 months old, was diagnosed with aplastic anemia. So I'm a little emotional because it just is reminding me of how upset and what she's going through and what she will go through. And a lot of the questions I had, you have answered when Jennifer asked you, what would you say to a mother whose child has just been diagnosed with a cancer or a rare or serious disease. But I was just wondering how, when you, and I forget this part of the story, and I'm sorry, did you have to choose a center, or were you automatically near a pediatric or children's specialty hospital?
Yes. So we live in Denver and really are fortunate here in Denver to have two pediatric hospitals. Our pediatrician, after the blood count, had asked us to meet with someone who he had trusted and referred before, the pediatric hematologist. And that was at one hospital. And we actually did end up meeting after the diagnosis, shortly after the diagnosis, we met with the other hospital and met with their pediatric hematology team as well. And I think that is, fortunately, we had the option to really speak, not necessarily for a second opinion, but really what felt like the best fit from a personality and education and open communication standpoint. So we had that option. I know there's many who aren't, but I definitely encourage patients and caregivers to seek out and meet with other health professionals to really get the best fit for them.
Right. Thank you. No, I appreciate it. It's just I was wondering how you made your decision, but at least you could narrow it down to two in your state. This parent, I live in New York, so of course I would like her to come to New York, but, they live in New Orleans. So, it's either whatever she chooses is not going to be, is not going to be an easy decision. But, again, I thank you for that. And I thank, Dr. Curran and Dr. Nichols, and I will, pass on information about the Leukemia and Lymphoma Society and, whatever information I've gotten myself. But thank you, and thanks again for nbmtLINK, Jennifer and Peggy.
Oh, thank you.
Absolutely. I think one thing too to mention, and we had a group share this because we actually went out of state looking at a clinical trial, and the advice that they gave us was just the power of community and support, emotional support. So, we felt we were chasing, what is the best care, and they really emphasized the importance of support for my husband Rich and myself and Quaid, and the fact that he had friends here, that we had family here in Colorado really helped secure our decision.
Okay, thank you. Thank you for that.
Thank you. Sarah, do we have any more questions?
We do. We can go ahead and take our next question now. Please go ahead.
Hi, this question is for Michelle. Michelle, you mentioned a 504 plan for your son. Did you have to initiate these accommodations for your son, or was there someone at the treatment center or the school that could assist you?
Great question. No, we did have to initiate it ourselves, and I think that's some advice that I really can give is that it sometimes felt like a full-time job, a second full-time job, because I continued to have to work for insurance. But it felt like, as I said, a second-time job, just trying to find what resources were available. So it wasn't just automatically initiated. After missing some time, the school district does offer remote support. But it wasn't until just talking with other people that we learned of the 504 and really what was needed. So he was able to get the 504 because he was missing so much school, and because of post-transplant being so immunocompromised, we had to try and keep him in his bubble as long as we could, and that really required him to miss a lot of school as well. So again, I think it's a great thing. He continues to keep on it. It allows for a little bit more time for testing, allows for extended absences, that type of thing. So really highly recommend it.
Thank you for sharing your story with us.
Thank you.
We'll take our next question now. Please go ahead.
Hi, I have a 3-year-old son who has ALL, and recently his body just swelled up, and we took him in. We didn't get any answers. So what type of advice do you give to a parent that is going through something and there are no other answers?
Dr. Curran, do you want to take that one?
Sure. It kind of cut out. What I heard was I think your 5-year-old son has ALL, and you didn't have answers, but you were cutting in and out for me.
Okay. So he's 3, and a couple of weeks ago, his body just swelled up, and we've never had that happen before. It's been a year since the diagnosis. So we took him in, and they did all the tests. Everything came back normal, but his body was still swollen, and they sent us home with no other options. So what type of advice would you give to me, when things are happening like that and there are no answers that your doctor can give you?
Yeah, and you said he has a diagnosis of leukemia?
Yes.
And he's currently on treatment? It was a year ago?
Yes, he's currently on treatment. He was diagnosed last May.
Okay. And the swelling has gone down or not gone down?
The swelling has gone down now, but occasionally I can see swelling in his cheek, but it'll go down at night.
Yeah. If he was sometimes with therapy there are side effects, and I don't know if the swelling is in relationship to some of the IV medicines or fluids he's getting. And so intermittent swelling that resolves is not really a concern. And and I can imagine they're testing the screening test to look at his kidney function, his liver function, looking at his heart occasionally with the echocardiogram. If those are functioning normal and things are and the swelling goes up and goes down, it's okay. If the swelling persists, or if he has any difficulty breathing, or if the swelling is in the mouth region, you can start thinking of allergic reactions. But if you're unhappy with the answers, without question, I think we've mentioned this, you have to have that trust with your physician, and it's okay to question them and to talk to other doctors and talk to the nurses. I mean, I will be the first one to tell you there's a lot of the nurses at these pediatric centers that they have me on experience 4 times. And we listen to them. So please use the resources you have there and use the different physicians.
Okay. Thank you.
Thank you. Any more questions?
There are no more questions at this time.
Okay. Well, I have one last question, and then I'll close us for today. This is a lot for a kid to take on, and I'm curious if anyone would like to comment as to how to help children with anxiety. Some of the things that in either Michelle, you with your own son, or Dr. Curran, anything that you in your practice try to do to try to help ease anxiety, just to give people some ideas if their child is struggling.
I'm happy to share what has really worked for our family. And I would say, yes, there's definitely the anxiety while he was in the hospital, and not just for Quaid. I have a really soft spot for these siblings as well. Not to mention for the parent as well as the parents. But again, I think there are a lot of emotional support, emotional health, mental health resources that are available as well. So again, Child Life, the licensed social workers, the nursing staff, as well as other nonprofits can provide a lot of support. We've definitely had our whole family in therapy, even after his treatment. There has been a bit of PTSD, if you will, and so that therapy has really helped just to talk about it, to talk about the anxiety. I think it's also helped. I mentioned that you need to find a way to vent and find a way to try and relax. So really getting to know our kids, getting to know us and what seems to help. I have one kid where art is really very valuable. Another kid needs to run around. And so it's really learning. And I think what I really want to emphasize is it's really, really normal. And so taking care of mental health is so important. And there are those resources available. You do have to work to find what they are, and then work to find what works for your family.
Thank you, Michelle. Dr. Curran, what are your thoughts?
I mean, again, echoing everything, we have a lot of experience here, and there are a lot of resources from Child Life to nursing staff to your physician and your family. We've talked about how a diagnosis of cancer, especially in a child, upends everything going on in your family, but you have to take care of your mental health. You have to find those outlets. The majority of pediatric cancer treatment is done within a multidisciplinary cancer center, and most of those, if not all, have some element of psychiatry or psychology, and really getting in to see them, even when things are seemingly feeling normal, is good. At the beginning, or even if you're in the middle of treatment, even when you're at the end, it's hopeful that there are support groups at your center. But all of these resources are there. Social workers also, if something is not at your center, the social worker has gone through a lot of these cases and can point you into a place that may be external to your center. It's the age of Zoom, so I'm sure some of these groups are actually probably turning to online support. And so hopefully that will expand our use of these.
Great. Well, thank you. And I thank all of you for being here today and helping our callers. I ask everyone to stay tuned for more information. We have a lot of programs coming up this month. We have a webinar about microbiome diet and how it can affect chronic graft versus host disease on September 29th, a webinar on sickle cell disease and transplant on the 23rd. And if you follow us on Facebook, this can help you get reminders and additional resources as well. If you'd like any further information about survivorship issues, supports available, or if you want to talk to a peer, you can call us at 1-800-LINK-BMT. So thank you to our speakers, our sponsors, our link partners, and for all of you joining us today. We wish you the best for you and your families, and if there's any way we can support you further, please reach out.